We are good to go, sir.
Okay. Good morning, folks. How are you all doing? Welcome to another episode of Friday webinar organized by SEMI and Unbuy. Today, we are here to learn about vascular injuries. Vascular emergencies include peripheral embolisms, trauma, acute limb ischemia, septic, diabetic foot, and many more. Vascular trauma is a major cause of limb loss in India. Most cases involve orthopedic injuries as well, primarily due to RTA. So today we have Dr. Devender Singh, who is a senior consultant vascular surgeon and endovascular surgery. He is also a clinical director with us, who is going to talk more about this. Dr. Devender Singh has been practicing since more than 25 years, and he has got a vast experience in dealing with both arterial and venous surgeries as well. He has more than 75 publications to his name and has given more than 100 guest talks across the world. Apart from that, he has also authorized in 3 chapters in his Handbook of Vascular Surgery. He has expertise in aortic surgeries, carotid surgeries, diabetic foot management, and very rare and complicated vascular surgeries. And he is an expert in limb salvage procedures. So I welcome you, sir, to this amazing evening of webinar. So happy learning, everybody, from this great speaker.
Thank you, Ranjith, and good evening to all. First of all, I appreciate that you have called me for this particular session. Vascular trauma has always been very close to my heart. 2 reasons. One, because mostly our young population, a very productive population, they get involved into this particular kind of injuries. And second good thing about trauma is that, these are virgin vessels, and if you repair nicely, if they come on time, then the results are phenomenally very good. Unlike other vascular procedures, these are the procedures, if you have done it nicely within the time, I think the results are significantly, remarkably very, very good. But just a second. But the problem of vascular trauma is every minute there is an accident. Every 5 minutes there is a death. Unfortunately, sadly, more people die of road accidents than disease in India. That is the sad affair for vascular trauma. When we discuss about the vascular trauma, either it is bleeding too much or it is not at all bleeding. That means vascular trauma has 2 components in the form of either hemorrhage or a gangrene. One of the significant fascination in surgery is repairing these vessels, and that was said long back. In the history of vascular repair or vascular ligation was started long back by Ambrose Paré. That was in 1552. And then subsequently 1759, the first vascular arterial repair was performed by Hallowell. That was the era then the arterial repair started, and then it has taken over. World War I, World War II, Korean War, Vietnam War, and then Iraqi War. Our amputation rates are declining because of the refinement in the surgical techniques and repair of blood vessels. Initial assessment, this is your job, and I am sure you are master in this, A, B, C, D, E. What I am interested in this, control of bleeding as well as re-evaluation of my case. That means a case who comes with a vascular injury. The most important part is control of bleeding. As I said, either they come with bleeding or they don't come with any bleeding in the form of gangrene. So when they come with the bleeding, first thing, I think if you have a controlled situation, then in that case, of course, you can explore the wound, you can see, because you have to mention in the MLC as well as you have to discuss with the other colleagues also. But if the conditions are not controlled, that means if the patient is coming middle of the night and you're all alone, and then if it looks like a very complex vascular trauma, my suggestion would be, do not open the wound unless until you are comfortable, unless until you call someone for the help. Because we have witnessed these patients who has got vascular injuries, momentarily the blood will stop because of a clot formation. The moment you start opening up the dressing with a gush of blood, the clots displaces and the bleeding starts. You are not in a position to control the bleeding. You start controlling the bleeding, probably the vessels will get retract, and then it becomes a very, very difficult situation. Patient is still not got admitted. There is an emergency. So it's definitely a very scary situation for all of us. So if you are in a good position, try to open and then explore the wound. If suppose you are not, call for the help and then you do it. So far as controlling is concerned, put pressure. If there is a bleeding, put pressure. Then take help of tourniquet and then splint and other things which can probably take control of the bleeding part. What is more important in my patients, vascular patient, is re-evaluation of these cases, because these patients, they may come with hypotension. You may not be able to feel pulse and you may be alarmed to call a vascular surgeon. But if suppose once after giving good amount of fluid and resuscitate the patient, there is a possibility of pulse coming back. So ruling out any vascular injury. Also, sometimes we see the patients will, you feel that movements are there, everything is fine. But as vascular trauma is a dynamic process, sometimes what happens, the vessels will go into spasm, subsequently there will be clot formation, thrombus formation, and then later on ischemia develops. So we should re-evaluate these patients time and again. This is how the patient present to us. In vascular trauma, any patient who comes with vascular trauma will have a systemic, regional, and local effect. In the pathophysiology, systemic effects, blood loss, patient can land up going into the shock. Now, the local and regional effects depends upon the mechanism of the injury, type of vessel injury. Gunshot injuries, massive soft tissue injuries, probably the insult to the collaterals will be more, and so the patients may present in a little bad shape. We do come across various type of vessel injuries. Most common is a laceration or a complete transection. We do see sometimes patients with partial transection. That means either a mild, moderate kind of a injury to the vessel. In those situations, sometimes what happens, pulse will be there, maybe feeble. Blood keep flowing, but there will be some amount of clot over that particular rent or partial injury over the vessel that may lead to a pseudoaneurysm subsequently. So one has to be very careful in situations where there is incomplete transection of the blood vessels. The real problem is basically a mismatch between oxygen delivery and metabolic need. The vulnerability of a tissue to ischemia depends on the basal energy requirement and metabolic substrate stores. Peripheral nerves are extremely vulnerable because of high basal energy requirement, as well as they don't have glycogen stores in them. So even short period of ischemic neural damage, the neuropathic symptoms, like in the form of paresthesia, loss of touch sensation, will start. And that is how I think our emergency people will be, they'll be remembering this, that I keep on asking whether the patient has got sensation, whether the patient has got movement or not. First thing I ask is movement and sensation, and then later on I ask for whether patient has pulse or not. Because peripheral nerves are extremely vulnerable and they are the first sign of arterial injury. So we should be careful in assessing these patients. Skeletal muscles, relatively tolerant, up to 4 hours, probably no histological changes, but beyond 6 hours, there is a significant histological changes and the changes becomes irreversible. And that is how the concept of 6 hours has come. The golden period of 6 hours, we usually keep discussing, you have to come in golden hours of 6 hours. The logic behind the golden hour of 6 hours is that after 6 hours, the irreversibility of the muscle tissue starts, and then it will be very difficult to revascularize and reperfuse these patients. But it is not always correct. 6 hours of golden rule doesn't always remain a standard rule, because sometimes many of our patients will have a good amount of collaterals. And if you have good amount of collaterals, that will extend the ischemic period, temporarily maintain basal aerobic metabolism, lessen the risk of reperfusion injuries. But If there are no collaterals, then the problem starts. And if there are no collaterals and if you try to reperfuse these patients' limbs, then there is always a chance of reperfusion injuries. Platelet aggregation, microvascular shutdown because of generation of superoxide anions as well as vasoconstrictions and capillary occlusion. This will lead to no reflow phenomena. This is very, very important for us to understand what exactly is no reflow phenomena, because the patient has come to emergency department, you have called us, we have come, we have counseled, and then we are taking the patient inside the operation theater. I have done a good surgery. I have replaced the segment with a vein graft. After replacing the segment, within few minutes, the graft gets blocked. It gets thrombosed. I again do a thrombectomy, start the flow, again it gets blocked. So this is known as no reflow phenomena. That means the blood is not circulating because of the distal resistance. The reason for that is because the capillary bed is completely clogged with a lot of superoxide anions and platelet aggregations. So this is very, very important. Prolonged and severe skeletal muscle ischemia releases myoglobin that is definitely a nephrotoxic, and potassium that may lead to arrhythmia. We catheterize each and every patient, and after catheterizing, we see the color of the urine. If the color of the urine is dark brown like a Coca-Cola, that suggests there is a significant amount of muscle injury, and these patients are likely to go for an amputation and would definitely require a nephrology consultation. Maybe there is a requirement of dialysis also. So patient who comes late, once we catheterize these patients, dark colored urine in the form of myoglobinuria suggests definitely advanced ischemia leading to muscle necrosis. Delay definitely increase the risk of irreversibility, ischemic injury, organ failure, and death. So what is most important is early recognition and treatment. And the goal should be reperfusion of the ischemic limb within 6 hours. Now, this is what it is very important to diagnose a patient when he comes with a road traffic accident, whether the patient has got a vascular injury or not. We have hard signs, we have soft signs. Hard signs, pulsatile bleeding, expanding hematoma, palpable thrill, audible bruit, or there is any evidence of regional ischemia in the form of 5 Ps. That means pallor, paresthesia, paralysis, pain, pulseless hypoiclothermia. If suppose these signs are present, that suggests definitely there is a vascular injury. But if they are not there, we should also rely on soft signs. History of moderate hemorrhage at the site of accident, injury leading to fractures, dislocation, penetrating wounds in proximity to the major arteries. Very important this. In proximity of the major artery. If suppose sometime we see a small punched out or some puncture wound around vessel, proximity to the vessel major arteries, should suspect probably underlying vascular injury as well. Diminished but palpable pulse. As I said, in cases where there is a partial injury to the blood vessel, there will be a clot, but the blood keep flowing. So you may get a diminished pulse, but that doesn't suggest that patient is free of vascular injury. It's like a clock which start tickling with the blood loss, progressive ischemia, compartment syndrome, and tissue necrosis. Irreversible damage after 4 hours. Speed basically means a golden hour. And even if the patient comes within an hour, there is always a chance of amputation, that to the tune of 6%. If patient comes within 1 to 3 hours, still there is a chance of amputation to the tune of 12%. There are many factors which we are going to discuss later. Now, in the mechanism of injuries, we have penetrating trauma, we have blunt trauma. This is what commonly we see in our scenario also. Penetrating trauma, gunshot wound, we are lucky not to have these patients. Stab, definitely we see. Blunt injuries, very, very common with us. High injuries, low injuries. This is an unusual case of vascular trauma. I don't know if somebody can guess what exactly has happened to this leg. A young lady, while she was walking, going to get some vegetables, suddenly got caught with a kite string. This is a case of kite string injury where there was a complete transaction of posterior tibial artery, nerve, and tendon. So we do have these different type of clinical scenarios where rather than having the regular mechanism of injuries, we do have a rare mechanism of injuries as well as. Overall vascular injuries, not very uncommon, 3 to 5% of long with associated with 3 to 5% of long bone fractures. In the specific circumstances like gunshot wound, definitely the incidence is very high. In cases of dislocation, knee dislocation, the risk of vascular injuries is still very, very high. That is the tune of 40 to 60%. Why the vascular injuries are frequent with fractures? Because of the proximity to the bone, tethering of the vessels at the joint, as we see commonly in supracondylar fractures. And of course, yes, sometimes we do have our vessels superficial, so they tend to get involved with the injury. In the diagnosis, the most important I feel is the physical examination. When the patient comes, I think we should make a point of examining the normal limb first, then the disease one. Tendency is that we start jumping on the leg or on the hand which is injured. But we should make a habit of first examining the normal hand or normal leg, and then we should go for the injured one. Because once we examine the normal hand or leg, we will come to know whether the pulse is good volume, pulse is there or not, patient is in hypotension or not, and then subsequently we can examine. So very important is to start with the normal examination, then go to the injured one. We have Doppler studies to, I'm sure, you know, all of are well aware of these things. You are doing day and night, all these things. Arteriogram remains the gold standard nowadays because people are more and more aware. They want more documentations. So if the kidney function is fine, we should subject these patients for an arteriogram, which remains the gold standard. Earlier days, when these facilities were not available, we used to explore with a very strong clinical suspicion. We used to take this patient to the theater and then explore and then do the repair. Arteriography, gold standard. As you see these patients, a good arteriogram or a good angiogram tell us many things. It not only tell us about the status of the vessel, which vessel is involved, transected, whether there is a collaterals, whether it can be reperfused or not, whether it is a kind of a good prognostic or it is going to be a very bad prognostic. If you see this leg seems to be okay, but if you compare with this leg, you see the size is so big. There is an injury out here. The size big means that suggests there is a good amount of muscle edema. That means definitely the patient has been having this problem or this injury since little long time. Good thing is that he's got a good collaterals, good distal flow. So if you see this bulk of muscle, definitely this patient would require a fasciotomy. So this is how we should read an angiogram. And multiple fractures, sometimes we will have not only one area of injury, we can have multiple areas of vessel injuries, like we do have multiple areas of fractures. So in those situations, these angiographic films or these angiography is going to be very, very helpful, because we have to probably then repair all the lesions which are involved in these patients. This is a case where there is a pseudoaneurysm. You see a partial tear in the vessel, and then there is a clot that is nothing but a pseudoaneurysm. Neglected injuries, pseudoaneurysm, pulse was palpable, patient was discharged. Later on, patient came with fall in BP, sepsis, and then we found out the patient has got a pseudoaneurysm, and then he was taken off the surgery and repaired. Now, different type of vascular injuries. We have spasm, we have intimal flaps, we have subintimal flaps, hematomas, laceration, transections. What is important in these injuries is that all requires treatment. There is no role of medical therapies. There is no role of observation. This is one case I must discuss with you all. By the way, the consent was taken for the presentation as well as photography. This small baby, she's 15 months old. She had a history of fall. She had a supracondylar fracture, went to a very I mean, good hospital, examined. She had movements. Pulse was not there. Fingers were pink. Saturation was 94, 96, and all those things. They thought probably baby is having a spasm. They subjected the baby for an operation. They did a supracondyle fixation by K-wire, and after the operation, the baby got into serious trouble. Hand become numb, color changed, ischemic, and that is where they thought there is a issue, there is a problem, there is a vascular injury. Very small baby, 15 months. I think this is the smallest baby I have operated. And then they have rushed to our hospital. The father is a doctor himself. We explained all the prognosis, and the only option was to explore. We explored. There was an injury to the brachial artery. It was tethered into the supracondyle fracture. There was injury, there was a clot. So we transected the part of the brachial artery and put a small vein graft, and then the circulation started. And fortunately, baby did very well after the procedure. Pulse palpable. So what is required is a continued evaluation. Even if you are thinking in terms of a spasm, please keep evaluating your patient, because vascular injuries are dynamic. Speed is definitely crucial, requires rapid resuscitation and urgent surgical treatment. Now, when it comes to surgical consideration, who goes first? Whether you should call a orthopedic surgeon, whether you should call a plastic surgeon, whether you should call a vascular surgeon, or whether general surgeon. Well, of course, if there is a road traffic accident with the polytrauma, you should go all. So far as the procedure is concerned, I personally feel our patient, they do come late to us. They come with good amount of ischemic injury. They come with advanced ischemia. So in my hospital, I've been working here for the last 2 decades. Patient who comes late, and majority of our patients, we did a study also, 99% of our patients will come after 6 hours. Or that means they may come after 10 hours, 12 hours. So there is a tendency of developing a good amount of ischemia, muscle edema. So what we do is, we go first as a vascular surgeon. We do a fasciotomy, look at the muscles are viable or not viable, and then we perform our bypass, reperfuse the leg, and then we allow our orthopedic guys to come and fix the fracture. There is always a scare that, if the orthopedic guys, they come and fix, there is a chance that my repair will get damaged. Believe me, honestly, it has happened only once in my 20 years of experience, because once we put a graft, they'll be very, very careful. So, I mean, it depends. If the patient comes late, I think we should be going first. Temporary shunt, in Western countries, there is a concept of putting a temporary shunt, and then, you allow orthopedic guys to repair, and then you do your repair. But my concept is, when you are introducing the temporary shunt, there is a possibility you might injure the endothelium inside. Vein is absolutely free. We have good amount of GSV available. So you can just take out a small piece of vein and do a anastomosis. No big deal. So even if it get damaged also, you can always repeat it. So I don't like the concept of temporary shunt, because there is always a chance of proximal and distal injuries. After you repair, if there is an injury, you are going to go back to the same scenario. In the fracture stabilization techniques, I think we should also play a role. We should tell our orthopedic colleagues that, yes, this is a patient where there is a sepsis, there is a requirement of this, so you should go for external fixator, or if the patient is fine, you can as well go for an internal fixation. Salvage, or we should go for an amputation. We are going to discuss this later on. Fasciotomies, definitely, I strongly feel that we should be liberal in doing fasciotomies. There's no harm in doing fasciotomy, but if you are not doing a fasciotomy, there is always a change in the scenario, because There is always a pressure inside. There is always edema inside. Once you reperfuse the limb, the pressure is going to build up more and more. The edema is going to increase more and more. So there is always a chance of developing a florid compartment after your surgical repair. So all the patient who comes late to us, please, we should be going for a labral fasciotomy. We have discussed about the bleeding, golden role of angiography, venous injuries. Yes, of course. Arterial injuries, we keep on discussing, but we don't discuss about the venous injuries. Life-threatening injuries, we should ligate the veins. But if the situation is controlled, I think those are the situations like for popliteal vein, femoral vein, iliac vein, we should be reconstructing these veins. Distal veins, tibial veins, you can ligate it off, but popliteal vein, femoral vein, if there is injury, we should try to reconstruct. The reason for that is because if we are not reconstructing, there is a possibility of developing a venous hypertension that will further hamper the circulation. Whatever repair we have done may also get affected. Arterial repair may also get affected. So the patency of an arterial graft also depends upon whether there is a good amount of venous back bleeding or venous flow or not. So if there is a possibility, should be repaired. This is how it looks. I think we should have to have this concept. Any arterial injury, there will be always a endothelial damage. If there is an endothelium damage, on that particular tear, there will be a clot formation. So the concept of removing the clot, the concept of just doing an angioplasty will not serve the function. It's a disease vessel in the sense the endothelium is gone. As you can see from here, there is a thrombus here, and this is the tear in the endothelium. If we are not going to take out this segment, it will get rethrombosed again. So the concept is vascular injuries, arterial injuries, venous injuries, there is no role for any thrombectomy. There is no role for any angioplasties. We have to take the segment out and repair with the vein graft, or if it is suitable, we can do as well end-to-end repair. This is a case where a patch was put in for a repair. Here is a case where end-to-end repair was done. This case, one of my very early case when I was probably a student in my Nizam's Institute of Medical Sciences, this case where I put my first vein graft, and this, fortunately, this slide is being mentioned by many now. If you go through the literature, many of people have copied this slide and they show a vein graft repaired like this. Another case of vein graft, another case of excision of contused segment and replacement with the vein graft. This is what recently we did. The patient had a dislocation of the knee joint, and then patient went to many hospitals. Somebody tried to do Fogati, and then patient did not get relief. Patient continued to have ischemia, came to us. We just took out the segment which was contused and replaced with a vein graft. Reimplantation, of course, this is primarily being done by our reconstructive unit team, but we do have a major role in assessing the blood vessels as well as reconstructing the blood vessels. This is we as a tertiary care center, we bound to get these type of patient. She was a medico, a third-year student, run over by a lorry, and you see the disaster. The abdomen was completely shattered, hostile abdomen, multiple perforation in the intestine. She had all over the muscles were gone completely. I mean, massive injury, and there was a massive injury to the leg as well. You see this. This girl was found to have her iliac artery was injured and contused. Now, I mean, what to do for this? I mean, here is a patient with the infected abdomen, hostile abdomen, where it is not possible for us to put a kind of a synthetic graft. And putting a vein graft may not be a good option because the size will not match. So what I did for this particular girl was I took out a piece of internal iliac artery from here, ligated and took out the piece of internal iliac artery and then replaced the segment of common iliac with a part of piece of internal iliac artery. And that is how we could able to restart the circulation. Another patient who we got a emergency call for this patient. Patient was taken up by an orthopedic team, and then they were suspecting spasm. They said probably, I think once they fix the femur, it will get relieved. So once they started opening, there was a big gush of blood. There was a huge kind of a hematoma inside. They called for the help. And this is what the picture was. There was a partial tear in the both vein and femoral artery. So we could able to control the bleeding. We repaired both artery and vein, and then patient required multiple transfusion, but subsequently he did well. Friends, we have to be careful with these type of pictures. When the patient comes with these kind of injuries, you see this ecchymosis all over, there's a big hematomas. This suggests underlying vascular injury. Clinically, you can make out something is going on, something is being happened inside. If not an arterial injury, a venous injury, and it's a major one. So you see these type of picture, we have to be careful about the patients and should also suspect a vascular injury. See this patient has got a kind of a ecchymosis here, this area. If you see carefully, patient has a depression here. It's a kind of a dimple sign, which we see in knee dislocation. The patient went to a some other hospital where they kind of reduce the dislocation and said nothing doing from their side, patient is fine. Patient pulse was not palpable. So then we suspected an injury and patient had a popliteal artery injury. We asked for our orthopedic guys help. They put an external fixator. We repaired the artery. This young boy, you see a puncture wound in the lower part of the abdomen. You see here a very, very small puncture wound, very small puncture wound here. I mean, you can't believe that the patient has got an iliac artery injury. This patient has the external iliac artery injury, which was repaired. Now, you see this very, very small puncture wound, which were otherwise the patient went to a local doctor. They said nothing doing. I mean, they are quite okay. Yes, of course, pulse was palpable in both the cases. Very small kind of, and they said even you don't require a kind of a stitch also. Leave it open, it will heal. But then both the patients, their family members were sort of, under my treatment. So they wanted me to examine and see. We also in our emergency completely, misdiagnosed the case because pulse was palpable, very small. They called me. I said, get a CT angiogram done because I am suspecting a partial tear with a kind of a small pseudoaneurysm. And that is what this patient had, a brachial artery, small laceration with a clot inside. And the other patient had a kind of a ulnar artery injury. So with a small hematoma. So, I mean, what exactly I want to show you is that if suppose there is an injury in the proximity of the vessel, should not take it light. We should suspect before it becomes too late. Well, friends, after devastating lower limb injury, the most difficult decision is whether to salvage the limb or whether to amputate the limb. Decisions are more important than incisions. This is something which we all should remember. Decisions are more important than incisions. And of course, saving a functional limb versus saving a life. This is the whole essence of treating a vascular major trauma. These patients, of course, you see these patients, it is difficult to reconstruct. Even if you reconstruct, it becomes a liability for the patient. So primary amputation. Again, ischemic, dead muscles, primary amputations. The question comes in this type of situation when you see the patient has got some vascularity, muscles, few muscles are contracting, few muscles are not contracting. So this is a scenario where I think we should go for a reconstruction. This patient, massive injury, looking very scary, but patient had good amount of reserve in terms of collaterals, so we could able to salvage the leg. Again, some of the example of where we should not jump for primary amputation, but we should reconstruct. But these patients requires a team, and it's basically a team approach. Complex vascular trauma involving orthopedic as well as plastic would definitely require a team approach where I think all the three specialties has to work hand in hand. And then only probably we'll be able to do justice to the patient and can give a good, viable, functional limb. What is important is functional limb. These are a few examples which we have done. But on the other hand, a heroic measures to save limb may sometimes leads to a repeated hospitalization, extensive complications, and a poor functional outcome. The salvage limb in some cases may become a liability instead of an asset. Can lead to physical, psychological, social, and functional trauma. The patient may be disabled and depressed in the end. So, saving a limb may sacrifice a life. That is, salvage may compromise a patient's quality of life in long run. So, one has to be very, very careful in taking a decision whether we should go for an amputation or we should salvage the limb. One of the comparison between limb salvage versus amputation, we have seen the total hospital stay, cost, re-employment days, and time to work much better if the patient has undergone amputation in these complex cases rather than limb salvage. Again, the cost of failed limb salvage for lower limb trauma, if you compare primary amputation with delayed amputation, hospitalization, operative procedures, hospital cost, lower expertise sepsis, all are more with delayed amputations, no doubt about that. This is a wonderful paper in NEJM published in 2002, an analysis of outcome of reconstruction or amputation after leg-threatening injuries. Definitely there is a, patient will have a lot of physical as well as psychological disturbance if we have to subject these patients after multiple futile reconstruction ultimately to an amputation. Salvage certainly is no guarantee of functional gain or employment. This was one of my patient when I was very enthusiastic in revascularizing all the limb. Patient RTC driver, where I repaired the popliteal artery, did a fasciotomy, skin grafting, and in the end you see patient has got a foot drop. Right leg not able to drive anymore. So sometime we should be also considering their profession and should accordingly guide them. With the changing scenario, what is important is quality of life. This gentleman, Neil Perry, became the first person to ever play with the prosthetic leg. 25 surgeries he underwent, 25 surgeries for reconstructing the leg, but ultimately he was subjected for an amputation, and now you see he became a superhero with the help of a prosthesis. So the goal of management first is limb salvage, life salvage, limb function, and quality of life. But just to say it needs an amputation or it needs salvage is no longer sufficient in 2024. Hard and fast reasons and pros and cons must be provided to support either stance. You call me to see a patient, I come as a consultant, come and say, oh, just go for an amputation or we will salvage. This should not be there now. Things have changed, people are aware, and we should also have some scientific data to prove that this patient requires an amputation and this patient definitely should be given a try for salvage. So the decision makings depends upon the patient's factor, mechanism of injury, and healthcare factors. Patient's factors is, of course, majority of these patients are young patients, so we should be proactive in salvaging. Whether the patient has any underlying disease, multi-systemic injuries, mechanism of injuries, whether the patient has got damage to bone, skin, muscle, nerves, vessels, everything is gone. Healthcare factors, whether there is an availability of facilities or not. if the patient can afford to have, multi-specialty treatment, and if you have a facilities of multi-specialties or multi-specialist available with you in the form of an orthopedic surgeon, plastic surgeon, general surgeon, neurosurgeon, vascular surgeon, so on and so on. Of course, with the background of intensive care and a very, very dedicated emergency department. So the decision making, so I think time has come that we should be having some objective factors to be assessed, and we should be having some scoring system, because if we can put this scoring system into prospects, we have something in hand. Yes, of course, I have taken a decision, or we have taken a decision of amputating this patient based on these criteria, based on this particular scoring system. So we have many scoring system. We have mangled extremity syndrome index, we have predictive salvage index, we have mangled extremity severity score, we have limb salvage, so and so many scoring system we have. So this is a mangled extremity severity index. This is mangled extremity severity score, predictive salvage index, limb salvage index system. We have NISSA scoring system. But when the patient comes to an emergency, I mean, we have to see the patient, we have to counsel the patients. So we have to have a simple scoring. It should be relatively simple. It should be independent. It should be readily available and highly accurate. I mean, it should not happen that, you are sitting with your chart and calculating the, how much is the score, and then you are coming to the patient relative. Doesn't give a good picture in the emergency department. So do we have that type of scoring system where, we can remember, we can put it into our mind, and then can place it in front of patients and then take a quick decision? Yes, this patient is going to go for an amputation, probably. And this patient, maybe we can salvage the leg. Mangled extremity severity score is 1, which is relatively very simple. And all of us in vascular department, when I was a trainee, used to put all our patients into this particular scoring system. This is a fairly very easy scoring system, maybe require a couple of rehearsal, and then probably you can start putting the patient in this particular, which have these criteria: soft tissues, injuries in terms of whether patient has got low injury, medium injury, high injury, very high injury, whether there is a limb ischemia, pulse is there or not, pulseless paresthesia, diminished, cool, paralyzed, insensitive, whether the patient has come in shock or not, or lastly, the age of the patient. This score system gets doubled after 6 hours. And if your score is less than 7, there is a good chance that you can salvage the leg. If the score is more than 7, again, there is a good chance that the patient is going to go for an amputation. But mind you, not for all cases, especially not for the upper limb, because upper limb muscle mass is less. We have good collateral. So do not try to put this particular scoring system for upper limb injuries. This is purely only for lower limb vascular trauma. So lastly, friends, the key points. What is most important is a clinical examination, and should also be subject the patient for CT angiography to look for more and more information in terms of reconstructing the vessel. Proper debridement is must. Liberal fasciotomy is must. We should avoid definitive vascular repair. You may call me for each and every case, but I should be very, very sensitive in picking up my patients. If the patient is hemodynamically unstable, patient has major wound contamination, life-threatening injuries, I think I should retract myself little back and should wait for things to get settled down. These are the few of our articles which got published. We have a couple of original articles regarding this particular management of vascular trauma. We did some research. We had 3 research papers with us. Unfortunately, we get awards in 3 papers where we did do scoring system, mesh scoring system as a predictor of limb salvage, or whether how reliable is this and all those things. There is an editorial. It's time to share the burden, the role of complex vascular trauma, and we have 5 various case reports for the vascular trauma patients. This is an image. Now it's been 15 years. A VVIP, he got into a little bit of trouble. He had a popliteal artery injury, a big shot. The whole political team was here, and patient had a popliteal artery injury. If you see this patient, now this scan was done after a decade, after 10 years, maybe 12 years or so. You see this popliteal artery, this is the popliteal artery, and this is a graft. You see this is a vein graft at the tibio-peroneal trunk, and this is another graft. Because of the high profile case, I did 2 vein graft for these patients. The pressure was so much and the limb was so precious, so I did 2 bypass. The reason for showing this is that usually young patient will end up in these kind of things, and their vessels are quite okay. So if we do catch hold of these patient in a good time and then repair them well, it's like a wonderful result, and patients will not require anything else. Lifelong hassle-free vascular repair. This was my first reimplantation, which I did in Yashoda some way back in 2007. Factory worker, both the wrist, at the level of wrist, both cut, and then we reimplanted. Another hand we reimplanted. Of course, phenomenal help from our other colleagues. This again, sometimes these trauma patients, they are so rewarding. Of course, they are very challenging, but they are so rewarding also. This is one of the unique case where the girl had a kind of injuries, vascular injuries to the neck, hand, leg, and then we repaired all the vessels. There was a lot of halla gulla for this particular case, and in the end, we could able to salvage the girl as well as leg, hand, and neck. Everything was fine. So this is what we get in reward also, that these patients, if we can diagnose them early, we can pick up them early, the results are phenomenally good. So I think that is all from my side. I'm open for the discussion. Thank you.
Thank you, sir. It was an excellent talk. So we could get many things from you. It was real. You have put in practice like what you have seen in real life. All this in your years of experience, you have just showed it to us. It was really thought-provoking to see, like how even 2 grafts being placed, 2 venous conduits being taken to just supplement the arterial injury. So it was good. So just to recap everything, so what sir has mentioned, so sir has spoken about the hard signs, the soft signs, the severity index scores, and he has spoken about the warm ischemic time and the importance, reperfusion injury, and rhabdomyolysis, and different imaging techniques that can be done, like Doppler, CT angio, and MR. So, sir, a few questions from my side before the others pitching. So, like say, a person has got an AK. He has a CKD patient on an AK or a new onset AK, probably because of an ischemia, because of a prolonged ischemic time, arterial injury. So, these patients, like, how good is MRA to CT angio?
See, I think, I understood. See, the thing is, yes, of course, this is a very common scenario with us. Recently, also, we did face a challenge with this. Patients will have a crush injury, they will have a crush syndrome, the creatinine will be on the higher side. So how to go about it? As I said, clinical suspicion is one. Palpate the normal first, the normal hand or leg, whatever, and then you come back to the injured one, you can make a difference. We do have handheld Doppler with us. I think it is also available with our hospitals also. We can check out whether there is any flow or not, whether there is a triphasic flow, basic biphasic flow, monophasic flow, or we can have a simple non-invasive Doppler scan. Invariably, Doppler scan is going to be a little challenged because these patients will have massive injuries, they will have dressings, they will have fractures, they'll not allow us. So Doppler becomes a little challenge for us, but at the same time, yes, of course, as we, if suppose there is a little bit of suspicion, and if we have time in hand, that means if we feel that leg is not so badly ischemic, then in those situations, I think we should hydrate the patient and should subject this patient with an MR angio rather than a CT angiography. We should not subject these patients at all for CT angio. It will further lead to issues with the kidney. So clinical examination, handheld Doppler, maybe a Doppler or an MR angiography in patients where there is a kidney insult, renal insult.
So one more question from my side, like say suppose any patient having a varicose vein and he had a trivial injury to the engorged veins and he has come with active bleeding profusely. So how do we manage in the emergency department? Can you just show some insight?
Yeah, first thing is with bleeding varicose vein, of course, then again a very common scenario in emergency department. Calm him down, calm his family members down, because what happens in varicose vein, the blood pumps like a jet. They get worried. They keep looking at the blood. So first thing is calm them down and make the patient lie down, lift the leg. The first thing you should do is lift the leg above the heart level, press it hard, and then keep it there for some time, put a tight bandage or crepe bandage. It will stop. Invariably, we have seen the bleeding will stop after some time because it's a venous blood, and then there will be a clot formations and it will stop. So once the bleeding stops, then probably yes, you can give a tight bandage. Then we can subject these patients for a Doppler scan, and then accordingly, whatever to be done has to be done for the varicose vein. But first thing, we should always educate these patients that calm them down, it will stop, make them lie down completely on the stretcher, ground or bed, and they lift the leg. The leg has to be lifted above the heart level.
Okay, sir. So one more thing to ask about. Say it's not exactly about an injury, but it is related to the vascular part. It's an emergency. Say suppose a patient has come with an acute limb ischemia and he has got not only the distal vessels ischemia. We have seen it even in the till femoral. So we suspect it could be even extending. Thrombus could be extending even till the aorta, the distal aorta. So how do we go about with these patients? The same thing. Can these things be? Heard about something like Lerich's syndrome, which is a aortoiliac thrombus. So is that only attributable to the atherosclerosis, or even a thrombus there can we name these things even for that?
So that is where the concept of proper clinical history is required. So we should be asking patient in detail about the history of claudication, whether the patient had claudication history or not, whether the patient has got diabetes, whether the patient has got any cardiac involvement, whether the patient has any kidney issues, comorbidities basically, or whether the patient has got any family history. So patient who has significant family history, patient who is otherwise a diabetic patient, hypertensive patient who is a smoker, patient who has an intermediate claudication history, and now they have come with a rest pain. So these are the patient where the patient has got now acute on chronic type of ischemia. It is not an acute ischemia alone. It's an acute and chronic type of ischemia where usually we will have some time to investigate these patients. There is another set of patient otherwise doing very well, no comorbidities. Suddenly there is a kind of paresthesia, numbness in both the leg. We should ask whether there is any cardiac history or not, whether there is a history of any embolism or not. These are the patients where they will have an acute insult. So these are the patients with acute lower limb ischemia. So these two set of patients we can only differentiate after asking a proper clinical history, as well as going little bit into detail of the examining the patient. Sometimes we do have, if you examine the, pulses, if you're not finding both the femoral, try to feel for the radials also. Patient good smoker, like nowadays we don't see TOs, but patient with TOs, they will not be having even the radial pulses also. A good smoker will not have. So there is definitely a very strong, I personally feel as a vascular surgeon in my specialty, clinical history examination is very, very important than doing a Doppler scan or an angiography, because most of the time, if you are not going to the detail of this patient, decision of reconstructing, suppose, you take the patient for thrombectomy, and if it's an acute and chronic, you are going to harm the patient more, because in acute on chronic patient, you have to go for a bypass operation. You are not supposed to do only a thrombectomy. So that is where the role of proper clinical history as well as examination plays a significant role.
I agree with you, sir. Thank you. Thanks a lot. If anybody has any other further questions, feel free to ask, because we might not get this person's valuable time. He's a very busy surgeon on his toes all the time. Apart from being in the hospital, he has got other. He goes for a walk in spite of all this chaos. In spite of having a very busy life, he keeps himself fit. He walks marathons. So getting his time is very, very difficult. So
no. I will definitely love to have more and more classes. I really enjoyed this session, and if you feel that it is going to benefit you or you guys, probably come forward. I will definitely have some more topics with me, and we will definitely discuss.
Definitely, sir. It's a pleasure hearing to you. Thank you. Thanks a lot. So I would like to thank Dr. Srinath Kumar, Organizing Chairman of Experts Appraisal on Emergency Medicine. He's HOD and Group Head Emergency Department, Yashoda Hospitals. Organizing Secretaries, Dr. Kiran Kumar, HOD Emergency Department, Yashoda Hospitals, Somajiguda. Dr. Vinith Ilapuram, Senior Consultant, Yashoda Hospitals. And Organizing Team, Dr. Sree Sowjanya, HOD Emergency Department, Hitec City, Yashoda Hospitals. Dr. Malay Mishra, HOD Secunderabad, and Dr. Raghu, Emergency HOD at Malakpet. So this opportunity for every week Friday webinars has been benefiting many of the students, and I am happy to be part of it. Thank you, sir. Thanks a lot.
Thank
we'll
you.
be very happy to catch you.
Thank you very much.
It's possible.
Look forward for other topics. Thank you.
Definitely, sir. Thank you.
Thank you.
Thanks a lot.